Hi, this is David, and what I'd like to talk about today is the way we monitor fetal well-being for outcome, and to fit this in with a model. And the model mainly has to do with the fact that there are two basic types of injury that a fetus could undergo during labor, or two types of struggles, and they may or may not exist on a continuum. And one is chronic insufficiency, where the baby is just in a chronic insufficient state, where the baby just isn't getting enough supply on a regular and chronic basis. And the other situation is acute insufficiency, where something suddenly happens, such that the baby is suddenly deprived of supply, and that's a more acute event. And by supply I mean really maternal supply to the baby through the placenta. So we'll start with a very brief review of the anatomy. So one of the very important things to note and to understand is that there are two circulatory systems in the placenta, a fetal circulatory system and a maternal circulatory system. So going back to our anatomy, imagine the yellow outline is the fetus, the white is the amnion, and these vessels here that I'm showing you right here, these vessels are the fetal vessels. And I've shown, in this case, the fetal umbilical artery in blue, because the umbilical artery actually carries deoxygenated blood to the placenta. So this is the baby's heart, and it's pumping deoxygenated blood to the placenta through two umbilical arteries. I only showed one. And the blood comes back in the umbilical vein, in this case oxygenated and red, where it goes to the heart, and then it gets pumped preferentially up here, preferentially to the brain, because the brain is really the organ that the baby most struggles to perfuse, that the baby is most interested in perfusing. So the fetal heart pumps blood down to the placenta, gets blood back from the placenta, which it circulates predominantly to the fetal brain. And I know this is a simplification, but it'll help me make some points. Now, so part of the placenta then will be the fetal blood that exists within these fetal vessels. And these fetal vessels are enclosed within a part of the placenta called the villi. So they branch from larger vessels here, from larger order vessels, to smaller order vessels down here that are almost at the level of capillaries, which are present within the last stage of the villi, or in other words, the terminal villi, which are seen here, 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 here. So that's where the fetal circulation is. And these villi are enclosed by a layer called trophoblast, and more specifically syncytiocytotrophoblasts, shown in this solid darker green. And then there are these layers of other trophoblast cells, these discontinuous cells that exist in clumps sort of around the villi, and they're called extravillous trophoblasts. And so that's where the baby's blood is within the villi, within the fetal vessels, and enclosed within the trophoblast outer lining of the villi. Now, this entire structure is bathed in maternal blood. The mother's blood isn't, unlike the fetal blood, the mother's blood is not contained in a vessel, but rather it bathes the entire villus structure. And it originates from what we call these remodeled spiral arteries. And I don't want to get into detail in that now, but the mother basically supplies free blood from these spiralized arteries that connect up to the maternal uterine artery. So the blood comes in this direction from the maternal right and left uterine artery into these spiral arteries that then enter this intervillous space, and the blood exchanges between mother and fetus right across here. So from free maternal blood existing in the intervillous space, across the syncytiotrophoblaст layer seen in green, and then across the capillary basement membrane and the capillary endothelium of the fetal microvasculature seen here. Now, in order for the maternal blood not to come in at too high pressures, which could be a problem, the baby has to remodel, has to change these maternal spiral arteries. And the cells that do that are the same as the cells that exist here, and they're similar to the trophoblast cells, and they're called extravillous trophoblasts, or EVT. They're very, very important. And they remodel the maternal spiral arteries right here. This is what I'm showing here, these green extravillous trophoblast cells. They're not really green, but just for the sake of the schema, these green extravillous trophoblast cells remodeling the maternal spiral artery and changing the fluid mechanics such that maternal blood could enter into the intervillous space with proper flow properties. Now, obviously, this maternal blood will have to carry a certain amount of oxygenation in order for the exchange to occur, but that won't be our focus here. Just to note that there is an exchange, and the maternal blood is delivering oxygen and nutrients and taking away waste, such as protons and stuff like that. And I actually didn't show, so just like there's maternal spiral arteries, there obviously has to be an exit system. So blood is constantly exchanged or circulated in the intervillous space by the mother. Now, where could things go wrong? So the two questions that I want to ask today is, where could things go wrong, and what can we measure as indices or flags of what's going on? And if there's one message I'd like to take you to take home, it's that what we're measuring is not the same as what could go wrong. And therefore, they're not direct measurements, but indirect measurements or surrogate measurements. We have very few direct measurements of intrauterine fetal pathophysiology. So let's start with what could go wrong. And really, in considering that, another concept that I want to introduce is chronic insufficiency. So chronic maternal undersupply to the placenta, chronic insufficiency. So the mother could either be supplying the baby like in a chronically low state, but the bottom line, what I'm saying is that the placenta could be chronically insufficient. The exchange parameters, the exchange for the fetus could be just chronically insufficient, or there could be an acute, sudden event that just abruptly deprives the baby of everything, and that would be like an acute asphyxia. So the placenta could be chronically insufficient, or there could be acute asphyxia. And these may either exist on a continuum, or they may be two entirely different things. So in terms of what could actually happen in real life, there could be the first thing that we could sometimes see is chronic maternal underperfusion. And that, clinically what it leads to is a growth-restricted or small baby. And the etiology of this, for example, could be impaired spiral artery remodeling. So if we go back to our diagram, imagine that this part is insufficient. Let's say the extravillous trophoblast didn't open up enough the spiral arteries. They didn't invite, or they didn't change enough spiral arteries so that this flow is insufficient. So then, the whole placenta, in a chronic way, is, let's say, seeing blood delivered not by something like this. You could think by analogy, not by a big, nice caliber bore, supply like this, but imagine it's seeing a narrow supply like this. So there's going to be less supply now coming in. So because of that, that's not something that happens suddenly. That's something that happens in a chronic state. And that is a deficit of spiral artery remodeling, and it's central to placental pathophysiology. It's said to be behind IUGR, especially early onset IUGR or intrauterine growth restriction. And that is a deficit in spiral artery remodeling. Now, one other point I just want to make to you. So let's just imagine the sequence, because don't forget there are two circulations here. So the mother, we're now talking about the maternal circulation via the spiral arteries, and we're saying that the maternal circulation via the spiral arteries in this context of chronic maternal underperfusion is going to be insufficient because the maternal arteries weren't remodeled enough, the extravillous trophoblast didn't remodel the spiral arteries enough to ensure sufficient delivery. So there's chronic delivery of the blood to the intervillous space. In that context, the fetus here is seeing insufficient maternal blood. And what the fetus does in exchange is it grows in a different way. And so if you could imagine here this is the fetal villus tree. And normally, let's say, the fetal villi grow, and then they branch, and then they branch again, and then they branch in order to increase in size. Imagine branches of a tree. And then at some point it has to sprout leaves, so it buds, and it creates the terminal villi, or the exchange units, these where the maternal-fetal exchange actually occurs. And this is nicely branched. This would be an example of a nicely branched good situation. But in the context of chronic maternal undersupply, the baby has to really optimize his exchanging, and he can't just waste energy on growing. It's like a tree that's growing in low light conditions. It can't grow big lush branches like these. It just has to do whatever it can to make as many leaves as possible in the little space it has, and it sacrifices branches, so it sacrifices size. And so what you have here is this part of the tree I've drawn is excessively budded to create these terminal units, but it's underbranched. See, it's overbudded or underbranched. And this pattern is what people like Dr. Kaufman and Dr. Kingdom used to call, excessive non-branching angiogenesis. And it's associated with the elaboration of certain angiogenic factors, like, for example, low PLGF and other angiogenic factors like FLT, which I won't get into. But you see pathologically this overbudded pattern, and pathologists refer to this as DVH, or distal villus hypoplasia, which is a bit of a misnomer, but that's what we call it, because you get these small little terminal villi and not very many branches. But, and I'll jump ahead, in this cascade of spiral artery remodeling, chronic maternal insufficiency, one thing that will start to happen is, imagine you're supplying equal blood volumes here and here. The blood volume in this system will be at higher resistances, much higher resistances. And that will cause problems. That could cause strain back for the fetus, such as to the baby's heart. This increased resistance in this type of a system. So in chronic spiral artery remodeling, one of the things that could eventually get the baby and almost cause acute trouble, even though it's not an acute insult, it could cause acute trouble, is the accumulation of increased resistance, and ultimately could cause an increased it could cause trouble to the baby and to the baby's heart, etc. So problem one that we spoke about is chronic maternal underperfusion. So the mother's not supplying enough blood to the placenta, and that leads to a litany of problems. The second thing that could happen is acute maternal underperfusion. And the way I would imagine that for you, if we go back to this diagram, imagine, let's say suddenly something happens so that the placenta separates. So imagine something happens so that right here the placenta almost falls off between mother and baby. So then that, and then this placenta divides and goes this way, and the baby, let's say, could deliver, but there's an acute separation here. And that's what and that would happen, for example, in the context of abruptio placenta, or abruption. Well, in that case of acute placental separation, what you would have is acute maternal insufficiency. Suddenly, no maternal supply. So that would be insult number 2, acute maternal insufficiency, and an example of that would be abruption. The third type of insult is chronic fetal insufficiency. And that would mean where over the time the fetal circulation is being diminished, and that's more rare. And the way you would imagine that is, let's say, for example, the baby starts to develop thrombi slowly, and slowly knocks out his circulation. And there is a condition that could possibly do that, and we call it FTV, or fetal thrombotic vasculopathy. But to make matters more complex, I'll tell you that this chronic fetal insufficiency of, chronic fetal thrombosis, fetal just slowly knocking out pieces of their circulation, happens more in this context of over-resistance, in this overbudded state. So, chronic intrauterine growth restriction caused by chronic spiral artery remodeling, which is chronic maternal insufficiency, can actually lead to chronic fetal insufficiency as a co-exacerbant because of poor supply within the fetal circulation, because it's hard to keep supplying if the resistances are so high. So that would be the most rare one, or the most difficult one to understand, is chronic fetal insufficiency. And the final insult I'd like to talk to you guys about is acute fetal insufficiency. So could there be an acute problem to the baby's circulation? Absolutely. And what would that be? For example, something happened to the umbilical cord, a knot in the umbilical cord right here, or a compression of the umbilical cord, or a prolapse, where the cord literally, let's say the membranes rupture, and the cord literally falls out and gets damaged by, sort of going into the birth canal. So just to summarize this, because this is important, there's a fetal circulation and a maternal circulation. And problems in you could have acute or chronic obstructions to either fetal or maternal circulation. Chronic obstruction to the maternal circulation leads to chronic placental underperfusion. It causes chronic growth restriction phenotype of the baby, and it's usually due to low spiral artery remodeling of the mother's spiral arteries, of the mom's spiral arteries that aren't chronically undersupplying the placenta, so that the placenta grows small with high resistances, as we saw, and the baby grows small. And the other thing that you see in this case is you get preferential head sparing. So it's what we call asymmetric. That's the chronic maternal underperfusion, and it's often caused by spiral artery remodeling. Then you could get the second insult that you could get also to the maternal circulation, but in this case it would be acute. It would be something sudden, would be acute maternal disruption, and that would be something like abruption, where the placenta just separates. Now that, whereas this is important. Whereas chronic maternal underperfusion really causes a growth problem, intrauterine growth restriction, acute maternal separation, acute maternal disruption, acute disruption to the maternal supply won't cause a growth problem. It's way too acute for that. It could cause asphyxia. It's basically, it could cause hypoxia and asphyxia. Asphyxia means lack of ability to exchange gases and nutrients at the level of the fetal tissue. So this is a growth insult, this one is a hypoxic insult. So usually acute insults are more hypoxic insults, and chronic insults are more growth insults. Now, the third insult that we mentioned is chronic fetal, which is more rare, and we won't deal with that in more detail. And then acute fetal. An acute fetal would be something like a cord prolapse, and once again, that's an acute event, and it could lead to asphyxia. So, I want to make two other points. When we talk about insults that happen, and when we talk about monitoring babies, looking to see how well the baby is doing, there's two stages at which you could do it. Antepartum, or prior to delivery, or intrapartum, or which is during delivery. Because antepartum, or prior to delivery, gives you a sense of how the baby is doing in general. But labor and delivery itself, because the uterus is contracting, is a dangerous time to baby, and the baby could get asphyxia. And the baby, in other words, the baby could get hypoxia, decreased oxygenation, decreased supply to his tissue. So my only point that I want to make now is the insults could either occur in the antepartum setting, which is during pregnancy but not during labor, or in the intrapartum setting, which is actually during labor itself. And therefore we have ways of monitoring babies in the antepartum setting and ways of monitoring babies in the intrapartum setting. The last point I want to make, and with this I'll close, and this is an important point. There is this notion in obstetrics that chronic insufficiencies decrease the amount of reserve in the placenta and predispose the baby to acute insufficiencies. So what I'm saying is, imagine you have a growth-restricted placenta. In this case, the baby is undergrown, he has asymmetric IUGR, he might have high resistances, but the baby is not hypoxic. The baby is not hypoxic. Or maybe a little hypoxic, but not very hypoxic. However, then let's say labor happens, or some acute event happens, the uterus contracts. This placenta has less reserve, whereas this placenta has more reserve. So a hypoxic insult, such as a cord event or just simply contraction of the uterus, labor itself, is much more likely to cause bad fetal outcomes, to cause true fetal hypoxia, to cause true fetal hypotension in this context than in this context. And so what I'm getting at here is, imagine it's like a car, and the car has to run on the racetrack. It has to sprint. It has to go fast. The sprint is sort of like the acute insult, and it just may be hard for the car to do it, and it might conk out. But a car that's going in good tune and with a good tank of gas is more likely to withstand the racetrack than a car that's already depleted. And so too to the placenta. The placenta is much more better able to withstand an acute insult if it has better chronic reserves. And that's a major relationship. So although we divided between chronic insults that cause growth restrictions and acute insults that cause hypoxia, it's true that placenta that are chronically insufficient are more vulnerable to acute insults. And this is why intrauterine growth restriction is also a risk factor for all sorts of things that cause hypoxia in the setting of labor. I know this was a little bit confusing, but this will be the end of this installment, and we'll continue on with monitoring in the next.